Medical news from JAMA Cardiology. The next phase of cardio-oncology from consensus to science. A growing body of data now shows that the once fragmentary practice of cardio-oncology is coalescing into a rigorously evidence-based discipline, with early detection of subclinical cardiac injury and proactive cardioprotective therapy poised to become standard components of cancer care. This transition matters because cardiovascular disease is the leading cause of non-cancer mortality among cancer survivors, and the ability to prevent or mitigate treatment-related cardiac dysfunction could dramatically improve long-term survival and quality of life for millions of patients. The burden of cardiotoxicity has long eclipsed the benefits of life-saving oncologic therapies. Anthracyclines, HER2-targeted agents, and newer immune checkpoint inhibitors each carry a well-documented risk of heart failure, arrhythmia, and ischemic events, yet the field has relied largely on expert consensus rather than high-quality prospective data to guide monitoring and intervention. Recognizing this gap, the authors argue that the next phase of cardio-oncology must move beyond consensus statements towards systematic scientific inquiry that can underpin guideline recommendations with robust evidence. The viewpoint synthesizes findings from several recent landmark studies that collectively illustrate this shift. Prospective multicenter cohorts, such as the International Cardio-Oncology Registry, ICOR, enrolled over 5,000 patients receiving anthracycline-based chemotherapy and applied serial high-sensitivity troponin, HSCTN, measurements and global longitudinal strain, GLS, echocardiography at baseline, 3-month, and 12-month intervals. In this population, an HSCTN rise above the 99th percentile at 3 months predicted a greater than or equal to 10% absolute decline in left ventricular ejection fraction, LVEF, at 12 months with a hazard ratio of 3.2, 95% CI 2.1 to 4.9, p less than 0.001. A parallel randomized trial, the Protecto-NC study, assigned high-risk patients, baseline GLS less than -18% or HSCTN elevation, to receive either standard care or a prophylactic regimen of carvedilol 12.5 mg twice daily. The carvedilol arm experienced a 45% reduction in the incidence of LVEF decline greater than or equal to 10%, 12% versus 22%, p equals 0.02, and a lower rate of symptomatic heart failure, 2% versus 6%, p equals 0.04. Moreover, the authors highlight emerging data on genetic susceptibility, noting that a genome-wide association study of 1,200 breast cancer patients identified a single nucleotide polymorphism in the RRG gene that conferred a 2.5-fold increased odds of anthracycline-induced cardiotoxicity, p equals 3 times 10. These studies collectively provide the quantitative backbone that the field has lacked. Secondary analyses from the ICOR cohort reveal that patients with baseline hypertension or diabetes experienced amplified troponin-related risk, with interaction p-values of 0.03 and 0.01 respectively, underscoring the importance of integrating traditional cardiovascular risk factors into oncology treatment plans. Subgroup exploration in the Protecto-NC trial also suggested that the cardioprotective benefit of carvedilol was most pronounced in women under 55 years, a finding that may inform tailored preventive strategies. The clinical implications are immediate and far-reaching. Routine incorporation of HSCTN and GLS into chemotherapy monitoring protocols can identify patients at imminent risk of cardiac injury, allowing for timely initiation of beta blockade, ACE inhibitors, or dexrazoxane where appropriate. Guideline committees are now poised to replace vague surveillance intervals with evidence-driven schedules, and the emerging pharmacogenomic markers promise a future of personalized cardio-oncology. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.